We'll start the first session of this focused on the laparoscopic herniaplasty, inguinal herniaplasty. First of all, welcome to Japan, the 11th World Congress of Endoscopic Surgery. And first presenter and the fourth presenter of this session is not appeared, or they don't give the PC data. Is here Dr. Rajsinha or Khan Han Wok? Isn't yet appeared? So we will be start from the second speakers. So that's it. Yeah. This session will be chaired us. I'm Atsushi Sugioka from Christian Health University, Nagoya, Aichi, and chaired by please.
My name is Kwang Yang Du. I'm from San Francisco with the University of California, San Francisco.
Good morning, Pradeep Chaubek from New Delhi, India.
Thank you. And in this session, each speaker allocated 7 minutes speak, and followed by the 5 minutes discussion. So let's start the session. Please, second session. Brij, Dr. Brij Agarwal. He speaks about the polypropylene mesh or lightweight mesh in inguinal hernia surgery. Then, a prospective randomized control study. Please study. Please start.
Yeah. Good morning, sir. It's a privilege to be speaking in front of dignitaries like you, especially Dr. Chobe. And I have learned my hernia watching him. I have nothing to disclose, and this study was presented at WCES and it has already been accepted for publication in surgical endoscopy. As you introduced, it's a comparative randomized study comparing the traditional polypropylene meshes and the lightweight meshes in inguinal hernia repair by totally extraperitoneal routes, and I am reporting very early results. As we all know, TEP herniography has already almost on a way to become a gold standard for inguinal hernia, and mesh is integral to successful repair. The mesh, the polypropylene content of the mesh induces cicatrization, leading to formation of mesh aponeurotic scar tissue complex, and this mass complex is integral to success of repair. However, the continuation of this cicatrization is not desirable because uncontrolled cicatrization can lead to involvement of the adjacent structures and leading to complications. Hence, there has been a lot of talk about moderating this process of cicatrization, and literature says it can be achieved by reducing the weight of the mesh by increasing the pore sizes of the mesh. And the perceived benefits of these lighter weight meshes are based upon implantation, explantation studies in animal models. There is scarcity of human trials of similar nature of these meshes in implantation studies. And earlier we had published a study of comparative study showing that lightweight meshes were better but difficult to handle and operative time was much larger. This study focuses on the patient outcomes in lightweight meshes. For the study, we had a model which was technique and host neutral because same host had both types of meshes in his body, and host was blind to the side of a particular mesh. It was a single center, single surgeon study by randomization by an independent doctor, and surgeon was blind to the post-operative follow-up. All sexually active married males having children were included, and they were candidates for bilateral inguinal hernia surgery. They were all screened for fitness for general anesthesia, and they had given informed consent for both types of the meshes to be put in their bodies. This is the demographic data. As we can see that age is slightly on the higher side, being 62.68 years average, since the patients were having bilateral hernia, so this is to be expected. Comorbidity was represented in all these patients, and majority of these patients had direct hernia because this was conducted on bilateral hernia patients. All surgeries were performed under general anesthesia, and the patients were asked to void just before coming to the table, so as to avoid need of catheterization. And I used tamsulosin before at bedtime if post-void residual urine is significant in preoperative follow-up. And as suggested by Bowney et al. In Surgical Endoscopy 2007, we don't use any energy sources, balloon, suction cannula, mesh fixation, or urethral catheters in inguinal herniorrhaphy, and 15 into 12.5 centimeter size is used. Patients were asked to report outcomes for both sides independently on 3rd day, 7th day, 3rd week, 3rd month, and at the end of 1st year. Endpoints were postoperative pain, which was evaluated by visual analog scale, and they were asked to report any discomfort, stiffness, stretch or drag sensation in inguinal lesion or lower abdomen, or any pain or discomfort affecting sexual activity. And recurrence, only clinical recurrence was taken as the endpoint. 25 candidates were included, hence 25 lightweight and 25 heavyweight polypropylene meshes were placed. All patients were operated on a day care basis. We didn't encounter any technical difficulty, conversion or complications, and all these 25 patients were followed up for complete 1 year. The interesting thing was that all patients could differentiate a different level of comfort in both the sides, and all this comfort level was better on the lightweight mesh size, and they felt that there was lesser stretch, stiffness and drag on the side where the lightweight mesh was used. And even if it was present with lightweight mesh, all these symptoms regressed by 3rd week, and even for the heavier traditional meshes, these symptoms disappeared by end of the 3rd month. Only 7 patients were willing to talk about, as we saw the age was on the higher side, so only 7 patients were willing to discuss their sexual life, and all of them reported that there is some discomfort after inguinal hernia surgery. As we can see in this table, which shows a visual analog scale 10 point of pain post-operative, pain showed significant improvement with the lightweight meshes till the end of 3rd month. But however, at the 1 year follow-up, pain difference was not statistically significant. So as we all know that unmoderated, unregulated cicatrization can involve the adjacent structures leading to infertility, ischemia, insult to the testis, and chronic groin pain. And all these factors impair the quality of life, including sexual life, according to the published literature. Lightweight meshes have been demonstrated by Novitinsky et al. To have shorter lasting inflammatory markers. Hence, they reduce the chances of interlinkaging of the myofibroblast, and hence less shrinkage of the mesh. That is why if technique neutral study is conducted, they say choice of mesh is more important determinant of the outcome rather than the technique. As we all know, early patient outcomes, chronic groin pain is a very important marker, and it can be debilitating and refractory to a variety of treatments like analgesic, nerve blocks, mesh excision, urectomies, and even radioablation. Hence, literature says lightweight meshes are considered better than traditional polypropylene meshes. Coming to the conclusion of our study, all we can say is that this is a good model to study 2 types of meshes: bilateral, male, sexually active, those who have completed their family patients, and they are a good model for this kind of study. And we feel, however it is a small study, that lightweight meshes should be preferred choice in TEP repair of the hernia. Thank you very much.
Thank you for your nice presentation. You demonstrated the lightweight mesh superiority compared to the polypropylene mesh. Yeah. Is it commercially available now?
Yeah, in India we are using it. So.
Yeah. Okay. Now this paper is open for the question and discussion. Any question or comment? Okay, Professor.
Congratulations, this is a wonderful paper and very ingenious way to study these problems with the same patient as control. I have a question for you. Usually a patient with bilateral hernias, one side is more symptomatic than the other side. So did you stratify according to that in terms of which side you put in the lightweight versus the heavier weight mesh? And is there any difference? That's one question. The other question would be that post-operatively, will the side that initially have more symptoms also have more symptoms post-operatively?
Thank you for the encouraging comment for this study. And as far as the questions, indication for surgery in these patients, symptomatology was basically a bulge in And on examination, if we had bilateral hernia, we include the patient. As far as the pain or differential extent of the bulge was considered, we did not stratify pre-operatively. And post-operatively also, we did not take these factors into account, whether the symptoms are more or less. According to the pre-operative presentation, the only criteria, because the observer was blind post-operatively, only criteria was post-operative groin pain, drag, whichever side it was, and we didn't know pre-operatively what was the status. So there was no comparison on that count.
Was it decided that which side you will put which mesh, or it was blinded and decided on the table?
It was decided by a sealed envelope in the operation theater itself, like the OT assistant will give a mesh. The first mesh has to be put on the right side and second mesh on the left side. Whatever was first, we had to put on the right side.
Okay.
Is there any comment? Question? Generally speaking, that in our country, laparoscopic approach is not so familiar, but I believe it's the best way to cure the approach. But how about in your country, the laparoscopic approach versus the conventional approach?
As I said in the beginning, I have grown surgically watching Dr. Chaube, and starting with the time when I was skeptical of laparoscopic hernia surgery, now at our institution, Ganganam Hospital, where we are working, I have not seen any open hernia repair in the last 3 years in my unit, and I have not heard anything in Dr. Chaube's department. So I think for us it is the gold standard, and I put bilateral meshes even if like Dr. Chaube does, but this study was confined to clinically evident bilateral hernias.
What is your opinion about the percentage of the laparoscopic approach?
In terms of the percentage, I think in the United States, somewhere between 15 and 20% are done laparoscopically. Probably more in big cities where there are specialists available. There was a decrease, I think, in terms of the interest in wanting to do laparoscopic repair after the VA studies. So a lot of people that wanted to learn and do laparoscopic repair stopped because of the concern that laparoscopic may not be better, but I think that's a misinterpretation.
Well, I think there's no doubt that laparoscopic surgery is a way ahead for any inguinal hernia surgery. It's just a matter of whether it should be done by the herniologist and specialized centers, or because we all believe that inguinal hernia surgery is an advanced laparoscopic procedure. It's not a basic laparoscopic procedure. So I think the surgeons who are sort of just staying on with a basic laparoscopic surgery, which means cholecystectomy, appendectomy, diagnostic and visualizers, these are the 4 basic laparoscopy, is fine, but I think a serious-minded laparoscopic surgeon surely will be better off with either TEP or TAPP. And it definitely produces. This afternoon I will be presenting the evidence which has been generated from all over the world. The evidence definitely points towards a better technique. Laparoscopy as a better technique as far as the recurrence is concerned, as far as the chronic pain is concerned, as far as even the timings. Laparoscopic surgery can be done in a much quicker fashion by experienced laparoscopic surgeon as compared to the conventional surgery.
I'd like to ask a question, Dr. Chaube. Would you, in India, are the routine general surgery trainees trained how to do laparoscopic hernia repair?
No, generally no. Because in the majority of the teaching institutions, still the conventional surgery is more frequently done. It's the specialized centers and specialized hospitals like ours where the departments of minimal access they are existing.
Well, see, we try to teach our residents how to do it, but the problem is it takes so many cases that it's almost impossible to teach a general surgeon how to do it, and we usually reserve this for laparoscopic fellows when they learn.
Yeah, so that's why we are conducting so many hernia workshops, congresses, and also we are doing the master classes for hernia, and also a lot of fellowships are available in our department because we do about 70-80 hernias every month. So there's a very quick way of learning it. and doing it again and again.
Yeah. Thank you very much. I also believe that laparoscopic inguinal herniaplasty repair is the best way to understanding the hernia anatomy for the young surgeon. So I expect that expanding the percentage for the laparoscopic herniaplasty also in Japan. Thank you.
Thank you, sir.
And we proceed the next topics.